Greetings. Let us talk about what you need to understand when you go into the ERCP room as a nurse or a technician. So, you need to appreciate what you see on the fluoroscopy monitor when your endoscopist injects dye into the bile duct. So, this is what it looks like. So, let me show you the different structures. You see the liver, intrahepatic ducts, right and left intrahepatic ducts join together to form the confluence of the hepatic ducts, and then it becomes common hepatic duct. Now we look at gallbladder, drains through cystic duct and joins the common hepatic duct to form the common bile duct. And the common bile duct enters into the duodenum at the major ampulla. So that's the path that the bile takes from the liver as the bile is secreted. As it comes down, the radicals get stored in the gallbladder and empties into the small intestine. Now let us learn about pancreas anatomy. The pancreas is situated uh, behind the stomach with the head around the uh, inside the C loop of the duodenum. So here is the pancreas tail, body, and the head. And there is a small process close to the D3, D4, that is the uncinate process. There is one main duct, the pancreatic main duct, and this is how it looks when injection is done for pancreaticogram. It goes from the head through the body and tail. And the main pancreatic duct opens at the major ampulla. Let us look at minor duct. It is a small duct that sometimes can connect into the main duct, or sometimes it could be just a blind end. And it drains through the minor ampulla. So we learned about the anatomy of the pancreas. Now let us learn about biliary pathology. When somebody comes in with a biliary colic, that is pain in the right side of the abdomen, it is because of a stone in the gallbladder that remains silent as long as it's in the gallbladder. But when it goes into the cystic duct and blocks the cystic duct and then comes back, that transient block leads to pain without inflammation and no fever and no jaundice, because the block is transient and it falls back. So all you have is pain. On the other hand, what happens when you have a patient with cholecystitis? In this case, again the gallstone goes from the gallbladder into the cystic duct and it gets stuck there and leads to persistent block. And when there is persistent block, the gallbladder cannot drain, it gets inflamed, and it can develop fluid and gangrene from inflammation. Gallbladder inflammation results in a lot of pain for a long period of time and then fever. But because the bile duct is not blocked, they don't have jaundice. How about what happens when the stone gets into the bile duct from the gallbladder? So here is a gallbladder stone that moves down into the bile duct and it blocks the bile drainage. When the bile drainage from the liver is blocked, the liver enzymes increase. So when you have uh, this problem with a blocked bile duct, they have biliary colic pain, they have liver enzymes that are elevated. And when you get an ultrasound or an MRI, the duct looks dilated above the stone. Sometimes you may see stone also. How about biliary pancreatitis? Here is a stone in the gallbladder. It goes down the bile duct and it blocks the ampulla of water. That means it blocks not only the bile duct opening, but also the pancreatic duct opening. And in this case, they will have severe pain because of blockage of the bile duct. Liver enzymes get elevated. Because of blockage of the pancreatic duct, pancreatic enzymes get elevated in the blood. And then when you do an ultrasound, you may see a dilated bile duct as well. So when you send a patient with gallbladder disease to surgery, what the surgeon does is he removes the gallbladder by putting a couple of clamps in the cystic duct. Sometimes the clamp may fall off and there may be a cystic duct leak or bile leak. During surgery, there may be injury to the hepatic duct because of current flying all over the place, and that could lead to hepatic duct leak. It may even lead to an aberrant duct that goes into the gallbladder fossa, that is duct of Luschka leak. And finally, sometimes the right hepatic duct can also get injured in cholecystectomy, especially difficult cholecystectomies. Then there could be a leak from here. All these leaks you can see when you do ERCP with the dye leaking out from different sections. Sometimes the injury could lead to stricture. So when a gallbladder is removed and the current inadvertently goes to the common hepatic duct, it can lead to post-operative biliary stricture. Another reason for bile duct stricture is cancer. In the head of the pancreas, pancreatic cancer, or cancer of the bile duct, cholangiocarcinoma. Or it could be hilar cancer, where the confluence of the ducts get blocked. Or you could have multiple strictures from inflammation. This is called primary sclerosing cholangitis. So you learned about a lot of anatomy about the biliary pathology. Now let us look at chronic pancreatitis. So here is the pancreas. We heard about the gland, we heard about the duct, and you will notice changes in the gland in the form of inflammation and fibrosis. And in the duct, there may be what is called narrowing or stricture. And above the stricture, stones can form, resulting in pancreatic stones. And then sometimes the duct can leak and create a pseudocyst. So in addition to problems in the pancreas gland and duct, the bile duct is going through the head of the pancreas, and that could be blocked as well, or a stricture can form, resulting in bile duct stricture in the head of the pancreas. You see that the pancreas is closely related to the duodenum. Inflammation can result in duodenal stricture as well. You see that splenic vein is close to the pancreas. That can get inflamed and result in thrombosis or a clot. And when there is a clot, you develop bypass routes, and those bypass routes could lead to gastric varices. So we've learned a lot about the anatomy of the bile duct and also anatomy of the pancreas and various pathology that one can encounter. I hope this is helpful. Thank you.